Okay, I'm just going to hope that the videos also work because it worked when I wasn't screen sharing. So hi, everyone. I'm Zoe. I'm one of the R3s here at Western. And for my talk, I will be talking about pericardial effusions on POCUS. And so the first half of it, we'll look at just looking at pericardial effusions on POCUS, and the second part will be when to get worried, so features of tamponade that we can look at as well. And we'll try to center it through a case that we saw. So starting with the case, it was an 85-year-old woman admitted at University Hospital, home alone under medicine. And her past medical history, she had coronary disease, complete heart block with a pacemaker, chronic kidney disease, and kind of the metabolic syndrome, hypertension, dyslipidemia, diabetes, and then some other things that I've listed there. In terms of the medications, by the time I had seen her, she'd actually gotten a few POCUS scans and I think a formal echo somewhere in the interim as well, but she was on aspirin and colchicine for pericarditis treatment. She was on some Keflex for cellulitis, and then the rest were her home meds. Notably, when she first came in, when they just saw the pericardial effusion, the Lasix was initially held, and then because she was stable, I gather the team had reintroduced it kind of throughout her stay. And then in terms of her, what she came in with, she had come in with, I think, 6 to 7 days of chest pain that was new for her and some shortness of breath. And some leg edema. She was sent in from her the GP to the emergency department, and in the emergency department she had a CT in workup of her respiratory symptoms, and that instantly commented on a large pericardial effusion. And it looked like really far back. I couldn't find a previous echo or like previous CTs of the chest anyway to comment on if it'd been there before. And then on exam clinically, she was stable, never hypotensive, never really tachycardic, and just on a couple liters of oxygen, maintaining her SATs. So before we go scan her, we'll talk about what pericardial effusions look like on ultrasound. So we know pericardial effusions is fluid in the pericardial sac. So on the left side there, we have a healthy heart. We all have like maybe about 10 cc's of pericardial fluid hanging out there, but because it's such a small volume, when we scan healthy hearts without effusions, you basically see the visceral and parietal pericardium as one layer, and it's hyperechoic and it surrounds the heart. On the other side, if you do have an effusion, we know fluid on ultrasound shows up as black and anechoic. So then you'll have a large anechoic layer surrounding the heart, and then you'll see the parietal pericardium getting separated from it. And hopefully that's a not subtle example of an effusion there. And then in terms of where you can see it, if the effusion is big enough, you can see it kind of in all 4 views that Hammam had mentioned, but usually the easiest and the best one to look at is the subcostal. And one of the perks, for instance, if you were in like a code situation and there's a lot going on in the chest area, and you just need to do your rule out kind of reversible etiologies, you have quick access in the subcostal, and it also gives you access to the IVC, which we can talk about when it comes to assessing for tamponade later as well. And these are just screen grabs from the patient I scanned, but so we'll get to see the videos a bit more later. But if I can convince you, there is some fluid, the peristernal long in the far field there, that's kind of hypoechoic and before the descending aorta. The peristernal shore was more kind of in systole when it contracted. And then there is some along, again, the far field in the apical 4, and then the subcostal, you'll see it a bit more, but then the videos will come in a bit. So when you see a pericardial effusion, what are some things we can comment on ultrasound? So first is size, which I'll talk a bit more on the next slide. You can comment on distribution. So again, is it circumferential? Is it hanging out more in the left heart or the right heart? And then complexity, is it simple or is there evidence of stranding or adhesions as shown in this picture here? And then features of tamponade. So in terms of pericardial effusion size, we measure the widest dimension when it's when the heart's in end diastole. So the heart is as relaxed as possible because things will look bigger. In systole, when the heart is contracting and you're far away from that parietal pericardium. And then this is kind of the general measurements that we use in terms of describing the size of pericardial effusions. So trivial is again when it's only seen in systole, so that'd be approximately less than 50 cc's. Less than 1 centimeter is small, so 50 to 100 cc's. Moderate is 1 to 2 centimeters, 100 to 500 cc's, and then large is greater than 2 centimeters, over 500. And I will say, because you should ideally measure in as many cardiac views as possible, because just looking at one may under or overestimate the size of the effusion. And this is just a nice picture showing kind of the different size from trivial, small, moderate to large of the effusion. And then before we get to scanning our patient, we'll talk about 2 pericardial effusion mimickers. And so the first mimicker, this is a video. You may see that there's a layer outside the heart and you're thinking like, oh, is that a pericardial effusion here? Perhaps like in the near field anteriorly there. But what that actually represents is epicardial fat pad. And so there are a couple of ways you can differentiate this from a pericardial effusion. So the first is fat is not fluid, and we said fluid would be black and anechoic. So the fat pad is more echogenic, which is why it looked a bit like grayer on the other compared to the effusions we had seen earlier in the presentation. And the next is you can kind of look at the distribution of where you're seeing it or the location of it. So pericardial effusions, assuming it's a free flowing and not complicated one, tends to hang out in the dependent regions as fluid does, or it can become circumferential. Whereas the epicardial fat pad sits more anteriorly in the heart, and it's most prominent, as you can see in the photo on the right there, in the right AV sulcus and some along the right heart. But you'll see along the LV free wall, there isn't really much epicardial fat pad there. And so if you're seeing just isolated pericardial separation anteriorly, that might make you think more likely fat pad, whereas you wouldn't expect to see the fat pad when you're looking posteriorly. And then lastly, the fat is attached to the heart. And so when the heart moves, the fat pad will move with it, but then the effusion, you wouldn't see it. So that's mimicker number one. This is number two. And we had said earlier that the fluid is anechoic, but we're seeing two anechoic layers here around the heart. And so what are the two layers? So the one closer to the heart is the pericardial fluid, and then the hyperechoic line is the pericardium, and then far field beyond that is actually pleural fluid. And the way to differentiate this is that the pericardial fluid should travel anterior to the descending aorta that we see there, and then pleural fluid is posterior to it. And so again, this is pericardial, aorta, and then pleural effusion posterior to it. Okay, so we know our mimickers. That's me with the sonocyte going to scan our patient, and we'll know what we're looking for looking for a pericardial effusion. So these are the scans. So in the parasternal long, you can see here that there is a pericardial effusion there, and it's traveling anterior to it, and some in the along the right heart here. But again, it kind of goes away when in diastole in that view. And then the parasternal short, you can see a little bit there as well. Kind of the ribs are in the way. And then the apical, she has the pacemaker, and you can see some kind of along the atria. And then this is just capturing more of the LV, the fluid there. And then this is the subcostal. Oh, they're all going at once. Okay, this is subcostal. And in this view, you can see there's actually a bit more fluid along the right side of the heart. And we tried to focus in there. Here is a decent view of the right atrium and the right ventricle, and we'll talk a bit more in the second half of our presentation in terms of why that's important when it comes to tamponade. This was her IVC, 3 centimeters and not more than 50% collapsible. And then this was us measuring the effusion, so 1.02. So far, based on the pictures we have and the scan we have, it looks like a simple pericardial effusion, and it's circumferential, but more along the right side, and it would be moderate in size because it's greater than the 1 centimeter, and the IVC looks plethoric. And clinically, the patient's stable, hence we have time to do this. So moving on to the second part of this talk, we'll talk a bit about tamponade. And before we move on, like we said before, tamponade is a clinical diagnosis, and POCUS will be a part of a tool in your toolkit to help you assess the patient. But it's a quick and easily accessible thing that can help you rule out a really important diagnosis. So I think this is one of the a great example of when POCUS makes a huge difference. And then tamponade physiology, as I'm sure we're all aware, that's basically the pericardial pressure because of the fluid buildup trumps everything, takes over the pressure of a cardiac chamber. And specifically, you get hemodynamic instability when it takes over the RV filling pressure or the RV end diastolic pressure. And then with the impaired filling, you get a drop in cardiac output and ultimately badness. And so then we'll talk a bit for the rest of the presentation on ultrasound findings and cardiac tamponade. This is a list I came up with from reading. I will say that I think the top half of the list are for people who perhaps maybe starting out like myself, are the easy ones to conceptualize and see. And then the last two are a bit more advanced, but we can touch on it as well. So the first thing when you think of tamponade, you have to have a pericardial effusion. They tend to be circumferential and moderate in size, but the key is that size does not is not like a direct predictor of tamponade. If anything, the rate of accumulation of the pericardial fluid is more concerning. So thinking like on the right side of the graph here, for someone who has a slowly, gradually accumulating pericardial effusion, like for instance, it's malignant, the heart has time to accommodate for this extra fluid over time. So it can accommodate for more fluid before it tips into tamponade physiology, versus someone who is, let's say, in a trauma and had acutely accumulated fluid in the pericardial space. They don't need that much fluid to run into trouble. So size is not what predicts tamponade. Okay, so we learned that you need to have an effusion to cause tamponade. The next thing that I think is a quick thing to look at and can help rule it out quite quickly is an IVC that's plethoric. And that's because it has a very high sensitivity of 97%. So if we know that IVC is normal, then you can pretty confidently say that you're not looking at tamponade. And just a quick refresher of what looking at IVC is. We look at two things. So the diameter, the cutoff is 2.1. So normal is less than 2.1 centimeters, and distended is above 2.1, and then you're looking at collapsibility greater than or less than 50%. And it's a rough estimate of the mean CVP. So normal IVC, most sensitive, it can help you rule out tamponade. And the next thing we'll look at is the collapsing chambers. So right atrial collapse in systole and right ventricle collapse in diastole. Okay, so, and the concept behind this is basically you want to look at the intracavitary chambers, the pressures when it's at its lowest, which would be in relaxation. And so for the RA, that's in systole. And when that cavitary pressure is low, the high pericardial pressure takes over, which is why you get that collapse of that chamber. And so in the RA systolic collapse, you can see a photo here. It's very indented on that top right picture there, which is the free wall being inverted because of the high pericardial pressure. If you're looking at it, there is furthermore, like specifically if it's over 33%, so 1/3 of the cardiac sacral systole, that actually increases its specificity to 100%, and then you can say like that is specific for there being tamponade. And because of the right atrial pressures are obviously lower compared to the ventricle, this is an early finding of tamponade, and you can assess this in the apical for the subcostal view. So that's the right atrial systolic collapse. We'll look at the RV next. This is also high in specificity. So if you see it, you're likely to, this helps you rule in tamponade. And the pressures here are lower during diastole. And the POCUS folks have described this as a man jumping on a trampoline. So let's see if we can convince ourselves in this video here. So this is a parasternal long. I mean, we're not really seeing the LVOT there, but we're thinking of RV in diastole. And so that would be when the mitral valve opens. And so when the valve opens, you can see that the RV is moving or collapsing towards the septum. So that's that RV diastolic collapse. The other thing you can look at is the M mode, which Hammam had mentioned earlier, which is basically looking at tissue movement in a still frame. And so this M mode correlates with that video actually. So you can see that the RV free wall moves towards the septum and is collapsing when the mitral valve opens. So that's the two collapsing chambers, one in systole, one in diastole, signs of tamponade. We talked about plethoric IVC sensitive to rule out, RA systolic collapse is early finding, RV diastolic collapse is specific. This one came up in Dr. Arnfield's textbook and some of the guidelines, so we can talk about it, but I didn't necessarily see it in my patient. But basically, it's changes in the ventricular volumes with respiration. So in tamponade, so this the first heart is inspiration, and then second is expiration, third heart is inspiration. And so because there's increased pericardial fluid and pressure, there's only so much space that the heart can work with. And so when one ventricle is increasing in volume, the septum moves towards the other at the expense of the other because there's just so much fixed space. And so what you're seeing in tamponade here is when you inspire or breathe in and the heart is flowing back to the right, the blood is flowing back to the right heart, the septum actually moves to the LV. And so you get an increase in RV size and a decrease in LV size with inspiration. And this you can see in the apical 4. And this I thought was a nice depiction of that. So this is again the M mode, but you can see that in inspiration, the RV size is bigger and the LV size is smaller as compared to expiration. Okay, and then moving on to some of the advanced things, and I'll try my best to explain this. So the first thing is exaggerated inflow variation across the tricuspid and mitral valve. And there were some different cutoffs, but the one I went off of was from the American Echocardiography Society was 60 and 30. And so here, again, usually in the apical four chamber, and you're putting the pulse wave Doppler over the mitral valve and over the tricuspid valve. And you're measuring the peaks, the tallest and the shortest. And again, this is the same physiology we mentioned before with the changes in respiration. And so you get exaggerated aspiration more than just what physiologically would happen. And so thinking of the right heart, because that's a bit easier. When you breathe in, again, the blood's rushing back, then the velocity is highest because the blood is coming back during inspiration and then lowest during expiration. And so you would take the difference of that too, and that's the percentage you'd use as your inflow variation cutoff. And so over 40 to 60, basically high variation is suggestive of tamponade. And then for the mitral valve, it's the other way around, where the peak is lower in inspiration and higher in expiration. And that is cutoff of 25 to 30%. Higher variation makes you worried that there's tamponade. And the last thing we can look at is hepatic vein diastolic flow reversal. Also, this is an expiration. And so also using PW over the hepatic vein. So what usually should happen, looking at this chart here, so negative is away from the probe, and because I'm looking at the hepatic vein, the blood is going away from my probe back to the heart, whereas above the baseline or positive is going towards the probe. During systole, when my RV is contracting, I think of that pulling the right atrium towards the apex as well. And so blood is getting sucked from the hepatic vein back to the IVC, back to the RA. And so it's away from the probe, and so it's negative. And then during diastole, when my RV relaxes, blood is flowing rapidly from RA to RV. And so it's still moving in that path away from my probe back to the heart. And that's what it normally should be. When you have tamponade, though, again, when you expire, looking at this middle heart here on the left diagram, the septum is going towards the RV. And so because of that tamponade physiology, the blood is actually going towards the probe backwards from the RA back to the hepatic vein, which is the diastolic flow reversal that you would see in tamponade. These two are kind of the more fancier advanced things, but I thought I'd bring it up in the presentation. So altogether, I think the easier to conceptualize ones are probably the first four or so. Like you see a decent sized diffusion, you look at the IVC to see if it's plethoric, and then you're looking at the right side of the heart to see if the chambers are being overcome by the pericardial pressures, essentially. Those are kind of my main takeaways from assessing for tamponade. And I thought this was cool, like Medical Jeopardy, we love the electrical ultrasounds, and this was just a nice picture of the heart swinging in a giant effusion. Not my patient, but I thought it was neat to look at. And so we'll go back to the case. My lady, again, clinically stable, so I'm not super worried about tamponade anyway. We had described the effusion already. Her IVC, just as a reminder, was plethoric and dilated and non-collapsible. But then if we look at this clip of her right heart, we see that, I'll move my cursor, the right atrium is not collapsing, and the RV is also not collapsing during diastole. I don't know that we captured it with respirations or anything, but I don't see that the septum is moving too abnormally here to comment on that respiratory variation. But overall, I don't think we captured any sonographic signs of tamponade, which was in keeping with her overall clinical picture. So it was just, our recommendations was just to monitor for clinical signs and can do serial scans and just keep a close eye to make sure she's tolerating that diuresis. In terms of her case outcome, just to wrap it up, I think the team stopped the colchicine and aspirin given the suspicion for pericarditis was low and she was having some side effects essentially. And I don't think we actually know the etiology of the pericardial effusion yet. I'm not sure how long it's been there. I tried to dig back, but couldn't find it. Her serologic workup was negative, although there was kind of a low pretest probability for that stuff anyway. And there was certainly no reason to drain it as far as our cardiology colleagues and our medicine colleagues were concerned. She'll have a repeat formal echo in some time, and I think see Dr. Yu and follow up. And I'd just like to end off, does POCUS make a difference? And I think particularly in this situation, it does. Like I mentioned, it's really readily accessible, it's quick, and it's non-invasive, and it can help rule out a life-threatening etiology of a patient that's sick in front of you. And I think one of the troubles with tamponade clinically is it's kind of non-specific, like you have the hypotension, elevated JVP, so this just scanning the patient quickly can help can help cross something off. And then just looking briefly into some of the studies, it looks like POCUS of pericardial effusions do translate to clinically relevant outcomes. So in the emergency department, they found that point of care or POCUS improved time to pericardial centesis. And then on the right was actually a Kingston study where they looked like over years, like a retrospective chart review, and the effusions that were identified on POCUS had just 28 hours to time to pericardial centesis compared to more than 2 days with other diagnostic modalities. So just another perk of the scan. And so that is the end of my presentation. Thank you, everyone. I don't know how to stop sharing. Annotate. Stop.
Thank you, Zoe. That was great. Yeah, some of the advanced stuff. Yeah, I mean, it's pretty advanced, and you have to have understanding of sort of spectral Doppler and stuff. But yeah, I agree with you. Like those first four, I usually tell people the few times to look at an IVC is when you see a pericardial effusion. Yeah, looking at the RV and RA collapse is important as well. And sometimes I find if they have a decent effusion, if they're tachycardic, it's hard to see in real time. And then, which is why QPAT's great. So you log in a QPAT, you can slow down your images to 1/4 the speed and then actually look properly when you're doing. So it's very important when you guys do scan, log in a QPAT, look at your images again, report the images. For all those on the call, a lot of names I don't recognize that I'm assuming are interested in POCUS. So anyway, thanks for that talk. I'll see if anyone has any questions or any comments or anything like that.
Could I just ask perhaps a logistical question? So like, let's say you were scanning someone and the RA and the RV are already looking not great. Like, are you still doing all the like advanced things and doing the pulse wave and things like that while you're there? Or are you at that point just kind of being like, I'm going to call for help, or does it just take you like no time that you might as well complete the scan while you're at it?
No. I mean, if I'm looking at something that looks concerning, I'm calling for help right away. If I'm in emerge somewhere, like if I'm in Toronto or something, or even like I mean, wherever you are, I mean, of course, and then once again, if there's collapse, there's going to be hemodynamic consequences to those collapse, right? So the sort of quantitative stuff is basically just quantifying what you're seeing qualitatively. So if you are seeing the RV, like the RA, you'll see the RA collapse, like that's early, and
Yeah.
sometimes you don't know if it's collapsing actually during systole or diastole. But you'll see the RA collapse. So if you're seeing the RV collapse and you're thinking, then yeah, call for help right away, obviously. And then hemodynamically, I think there was a patient on the floor, I think a couple of years ago when we were doing the POCUS fellowship that they picked up like significant, he was in tapenade. And I remember the ICU, they called ICU and then they basically squeezing bags of saline into this person while they were able to wait for cardio or bring them down to the ICU. And I think actually it was the ICU fellow that ended up doing the tap. But you don't want to wait for the intervention, right? If they're unstable, just basically start treating them, squeeze bags of fluid into them, call cardio, whoever, ICU, whoever's going to do your tap. And then I mean, if you're there and the patient's clinically fine, then once you get the help, then sure, just for
the fancy stuff.
Point. Yeah, you can do the fancy stuff. But once again, I mean, I find more often this quantitative stuff is not. I don't use it that much in real life. It's rare. And even when you guys scan, I think there was one patient that we did a sort of a stroke volume assessment, which is kind of useful because she was, quite shocky. And so it's a one-off cases, but most of the time the qualitative stuff will give you, because you have a pretest probability, you have a clinical impression of what's going on, and you're just trying to confirm that, yeah, I've got the right diagnosis, that this is what needs to happen. And you make that happen as soon as possible.
And Chloe, you alluded to already sort of this clinical sonographic integration that we always have to do with every case that we see. And you were talking about the clinical signs of tamponade. So I think you just didn't specifically mention in your presentation because you're focusing on the ultrasound, but indeed, her pulsus paradoxus was assessed serially. I think there was at the very beginning on a mission, there was concern about elevated pulsus paradoxus, but subsequently with the one half working manual cuff that we have on the floor, we found that her pulses was generally 8, 9, less than 10 basically throughout her hospital stay. So you come in with your clinical impression with the pulsus paradoxus, and then you start getting your scan. And if you do see the chamber collapse and you knew that the pulses was already kind of borderline or a little elevated on your initial clinical assessment, then sure, right? You don't really need to go further with the advanced hemodynamics and just start treatment or start calling for help.
Makes sense. In my mind, you guys just do it in like 2 minutes and then you guys are done.
Yeah. Okay, does anyone have any other final questions or comments? All right. Okay. Well, thanks everyone for joining. Hopefully, you guys found this helpful and educational, and we will see you guys next month. Okay. Thanks, Zoe. Thanks, Mom. Take care.
Thank you.
Bye.